and Wellbeing Council, I welcome all of you to this spotlight session on the occasion of World Thalassemia Day, which is an initiative of the IHW Council and powered by Hemex DX. I'm your host, Dr. Behjat, and today we'll be discussing about prevention and early detection of beta thalassemia. And to discuss about this bleeding disorder, I have with me Dr. Akshat Jain, who's the director of the Inherited Bleeding Disorder Programs and Assistant Professor, Pediatrics and Clinical Medicine, Loma Linda University School of Medicine and Children's Hospital. Welcome to the discussion, Dr. Jain.
Thank you, Dr. Behjat. Thank you for having me.
So we'll be starting with the slides where Dr. Jain would be introducing us to the prevention and early detection of beta thalassemia, and followed by our question and answer session. So, sir, over to you.
Okay, thank you. Dr. Behjat, let me know if the screen is being shared appropriately.
I can share. I can see your screen.
So today is very apt that we talk about thalassemia as the world is celebrating the warriors, the scientists, and the physicians and caregivers for people who care for thalassemia. As Dr. Behjat mentioned, I am Dr. Akshat Jain. I direct the hematology program here in California, United States of America, but I'm a person of Indian origin originally. And having seen thalassemia throughout my life growing up, this is something that is very relevant to discuss, especially not just with India perspective, but global perspective, because thalassemia is a genetic condition where people get affected from generation to generation by this disease because of carriers, which are parents that can sometimes get together without knowing their status and inadvertently have a child that suffers from the severe disease. It is a genetic disease, and this diagram basically demonstrates how two people who are carriers that are shown here in purple get together and have a child that could have a 1 in 4 chance of having a severe disease. Now, what is severe thalassemia? It's important to know. Thalassemia is a condition where the blood doesn't form. That means the red blood cells doesn't exist. So people with thalassemia, to live and survive, need to have a blood transfusion every month for the rest of their lives to be able to have somebody else's blood flow into their bloodstream and circulation in order to be able to do normal functions like breathing and walking and talking. That is why it's such an important thing, and the importance of diagnosing and detecting people with blood disorders, especially thalassemia and sickle cell disease, which affect people in Southeast Asia, especially our country, India, and globally, is an extremely important thing. The earlier the detection of thalassemia or sickle cell disease happen, the better a chance to get ahead of the disease and control the symptoms. Prevention, early diagnosis and prevention can prevent a lot of end organ damage. It has a significant impact on public health because people with thalassemia and sickle cell disease, two disorders of red blood cells, lead to a lot of distress in patients requiring blood transfusion, requiring pain medication, requiring hospitalization, and a lot of suffering, which all adds up into the public health aspect of what a country needs to spend on to care for its citizens. So if diagnosed early and detected early and correctly, the patients can access or have care so that they do not decompensate and do not require to be in the hospital all the time. It reduces the disease burden and puts the country on the path to success. It reduces healthcare cost and certainly brings out better management guidelines. As more patients are diagnosed, everybody recognizes the need to treat those patients. If you don't diagnose the patients and not know what the patients are and where the patients are, then really there is no awareness about creating health programs to treat the disease. It is important to know that a sister disorder from thalassemia, which is sickle cell disease, especially in India, affects people right, left, and center, especially in the tribal areas of our country. And about 20% of the children die before they can get to see their third birthday. It's that severe and that's important, which is why we need to talk about the condition. About 30% of children with sickle cell disease live in the tribal community and they die before reaching adulthood. That's 3 out of 7 children in the tribal areas in our country, India, that don't make it to adulthood because they die of sickle cell disease and complications. With thalassemia, about 15,000 babies are born every year with severe thalassemia in our country, something that can easily be prevented and easily be controlled ahead of time so that these babies don't get that death sentence. This is why it's screening for these disorders are important. This map basically shows a color coded diagram of showing how prevalent all of these diseases are. Unfortunately, the diseases don't follow a clear pattern. 2 plus 2 is not always 4 when it comes to these blood disorders. So there are many states, as you can see highlighted in red, that have an overlap where people do develop sickle cell disease along with thalassemia, making the picture even more complicated and diagnosing these patients incorrectly. There are certain areas shown here in pink, especially Telangana, Chhattisgarh, and Jharkhand, that are the deep belts where sickle cell disease is present in about 50% of people, especially in the tribal areas of Chhattisgarh, Jharkhand, and some areas in Telangana. Hemoglobin E, which is another type of red blood cell disorder that leads to anemia, can also happen in a combination with thalassemia. Hemoglobin E can alone affect the people, especially in the northeastern part of our country. And pure beta thalassemia, commonly seen in and around the Sindhi community in the Punjab and Delhi, Haryana area, and West Bengal, as shown here in yellow. So it's important to understand that our country has a lot of people that suffer from red blood cell disorders. And many a times, especially these young children who suffer from these diseases, cannot actually get a correct diagnosis because of so much overlap of this disorder. Fortunately, there are ways to diagnose, which is how we have historically found that this blue or this yellow belt shown here is prevalent or big deep belt of thalassemia, especially shown here in red and in yellow. The carrier rate could be as much as 3 to 4% of population, meaning 3 or 4 out of 100 people walking on the streets, especially in areas like Telangana or Uttaranchal or Northeast, could be affected by severe thalassemia and they not know about it. So it's important to know that hemoglobin S or sickle cell disease, as shown here, is prevalent in our country across the middle belt of the country. Hemoglobin S, which is remarked by hemoglobin sickle cell, and then hemoglobin E, remarked by hemoglobin E thalassemia in the northeastern states, could be as high as 50% of carriers, meaning 50% of people walking on the streets in our northeastern states could be carriers of hemoglobin E, a type of thalassemia, and don't know about it. So it's important to know that our country suffers, or people from our country, all over the country in various parts, suffer from these diseases. So it's important to understand that there is right awareness and education programs like these, where experts with sickle cell disease and thalassemia get to talk about why it's important. The problem currently, unfortunately, there is lack of awareness and education. People don't know about their status, so they get ahead and start having family planning without having the right knowledge. And that leads to these children being born every year and suffer all their lives. Most people in many of these states have limited access to screening. Even if they would want to know, even if they know that something's wrong in their family and they know that there are family members who suffer from bleeding or the red blood disorders and need blood transfusion, sometimes still cannot get access to right testing on the right time, even if they would want to. Treatments like blood transfusions, treatments like medicines to treat sickle cell disease are very expensive and sometimes not accessible to most patients, especially in the tribal areas. I have a unique position being in the United States and running sickle cell and thalassemia specialty programs for over 20 years in the United States of America. So it is not lost on me to see this difference between my home country, India, and how we do things in the United States, which is really why it's so important. Here in the United States, we have maybe 3 or 4 medicines to take care and treat children with sickle cell disease, adults with sickle cell disease. Very recently, due to our severe investment into research and a lot of interest around curing these diseases, we were able to discover and find medications and therapies like gene therapy to cure sickle cell and disease thalassemia once and for all in patients. And we have a lot of children and young adults taking advantage of that therapy and getting cured. But unfortunately, in our country, we don't even have correct screening and diagnostic facilities to do the right exact diagnosis. Supportive care, which requires genetic counseling, psychosocial support for mental health, pain management, medication safety, blood bank safety, all of those things that make a program important for people with thalassemia and sickle cell disease, unfortunately don't exist outside tier 1 cities. Having said that, the government, especially under the leadership of the current Prime Minister, the current Health Minister, have taken deep steps in creating awareness around blood disorders, especially sickle cell disease. And it is the right step in the right direction, but there is a lot of work that needs to be done. This is just a picture, a complicated picture, just to show how important it is to make the right diagnosis. This is what we do as hematology specialists or hematologists who have had proper full board certified training to be able to diagnose these patients correctly. Subtypes of thalassemia, subtypes of sickle cell disease, the combination, all of that requires specialized correct testing. When we started doing this in the United States about 60, 70 years ago, we had the same challenges that India faces today. How do we develop technology? How do we make it available? How do we make it cost effective and cheap? And how do we take it to the people that are all around the country? United States of America has the size of 5 times the size of India. Yet every child, every boy and girl born in United States over the past 50 years, right from the time they're born, before they leave the hospital, gets screened for sickle cell disease and thalassemia, which is a mandatory thing. And this is why we know exactly how many patients there are, what is their exact diagnosis, their subtype of thalassemia, subtype of sickle cell disease, and we know who are the patients who are going to get in trouble. So public health programs are directed towards those areas, even if they are living in far rural areas of United States, where the challenges are very similar to our tribal people in India. Not having access to electricity, not having access to transportation, being away from a major hospital, all of those things still exist in the United States. But we have had proper training and people who are interested in treating these diseases and taking care of these patients, which is why the disease has gotten to a point where we have cure available for these patients. Another picture just showing not doing the correct way of doing hemoglobin testing or blood testing can give wrong diagnosis and those patients can suffer. So important investment into right diagnostic technology that is available right there and then. Versus, for example, if there is a specimen, a blood test that is taken and it stays in the laboratory for a long period of time, wrong results and wrong type of hemoglobinopathy or thalassemia can be diagnosed because of false testing that can show high levels and low levels. It's very important that right testing, especially point of care testing, quickly testing in the community, in the field, in the Anganwadi areas, in the districts can happen so that people can get right diagnosis. Just a diagnosis and technologies that we have available is all available and the training is available. So if somebody wants to learn, there are all the ways to diagnose the people correctly. Newborn screening, which is the test for all newborns born in the country. Good community screening in school, colleges, temples, religious organizations, wherever these patients are, if we can get support, that way we can go and get people diagnosed and tested and be able to let them know their status so they can make right informed decisions. Having access to right education, right people, and the right level of training, not just having training for the name's sake. People who can understand and are specialists in this disorder, that are available and accessible to everybody, not just people in tier 1 cities, but tier 2, tier 3, and even rural areas. So with that, I will end the presentation and we can go to the next part of our conversation, Dr. Bejar. So I'll stop sharing my screen. And if you have questions, and I know you do, we can talk about those now.
Yeah, sure. Thank you, Dr. Akshat Jain. That indeed was a very, very descriptive overview of the disease that you've explained to us. Talking about the significance of antenatal and premarital screenings, could you explain how these screenings help in early detection and prevention of hemoglobinopathies, and how is it done in other countries around the globe?
Absolutely. Very, very apt question. And I think this is probably the most important question. Uh, let's say if there is an antenatal test or somebody is running a obstetrician or OBGYN or labor and delivery clinic to diagnose people with high risk gene mutations or high risk thalassemia syndromes. If those testing and screening can be done right there at the Janana hospital or at the Anganwadi or by the Anganwadi worker for somebody when they diagnose or then find out that they are pregnant, that prenatal or antenatal testing can tell them or at least give them an informed decision about their thalassemia status. What would be best, how we do it in the United States is because every newborn gets tested right at the time of their birth, 16, 17, 18, 20 years later, when they decide to have a child of their own, they're well aware of their status, whether they have sickle cell carrier status or thalassemia carrier status, and what type of thalassemia carrier. Beta thalassemia, alpha thalassemia, hemoglobin E thalassemia, all the subtype of thalassemias are already diagnosed and people are aware. So when they go ahead and decide to have a child or marry somebody to decide to have a child, they make sure that that other person gets screened for thalassemia too. It takes two carriers to have a child with severe disease. So having this awareness and knowledge, just by having an empowered, informed decision before they can extend that gift of life to their future offsprings, it makes all the difference. Now, this is what we need. I hope we will be able to see happen in our country in India in the next 5 or 10 years. But just to give a glimpse, we are actually doing intranatal testing, intra-pregnancy testing by doing chorionic villi sampling. That is a technique that we have mastered over many, many years without affecting the fetus or pregnancy. We are able to diagnose by just doing either checking the fluid from the amniotic sac, which is what surrounds the fetus, or by doing a sample from the umbilical cord, or just now even testing for mother's blood to just diagnose if the child that is growing inside the womb of that mother has a type of thalassemia or not. And especially in alpha thalassemia, we are even able to do blood transfusions to keep that child alive while the child is still in the womb. That's how advanced we have been. And we are applying gene therapy techniques to cure thalassemia in the unborn baby just by knowing the status. So that's the power of perinatal and antenatal testing.
Dr. Akshat, coming to the clinical implications of current diagnosis in patients with hemoglobinopathies, especially compound heterozygous states, why is timely diagnosis important, looking at the severity of the condition and particularly focusing on the compound heterozygous condition and the reasons of its prevalence in Southeast Asia, especially in India?
Yes, very, very technical question. So I'll try to simplify it. But compound heterozygote, the term that you used, is basically in simple words, a combination of two disorders. In the slides that I showed you before, there are a lot of areas where there is an overlap, where people can have sickle cell and can have beta thalassemia together, or sickle cell and alpha thalassemia together, or hemoglobin E and thalassemia together. That makes it complicated. That makes it complicated because people who have the pure sickle cell type or people who have the pure beta thalassemia type behave very differently as compared to people who have combinations. The way we address challenges of people who require clinical care before they can end up into a crisis, before they end up into the trouble and get to the hospital or suffer a lot, and sometimes die from complications. If we know the right diagnosis, for example, if we know somebody has pure SS or sickle cell severe disease, early utilization of that information right there and then and starting medications that can cause their hemoglobin to go up can prevent them from a lot of suffering, from pain, from complications such as paralysis. Imagine a 3-year-old little child suffering from full-on paralysis of the body because of sickle cell complications in the brain. A complication like paralysis that happens to people when they're in their 80s and 90s, happening that in 3 years of age, that is something that happens all the time. Just by knowing if they what is their sickle cell or thalassemia status or hemoglobinopathy status correctly can allow us to do early diagnosis and early intervention. A lot of children with severe beta thalassemia major suffer from growth retardation, suffer from falling back in school, not being able to learn properly, not being able to grow properly. These complications can be prevented if we know the diagnosis very, very early. People with S alpha thalassemia tend to do much better than people with SS type of sickle cell disease. Then another example would be somebody who has sickle beta thalassemia, sickle beta plus thalassemia, which is a subtype of sickle thalassemia. These are people who don't require a whole lot of blood transfusions. But if somebody recognizes that they have sickle beta thalassemia, or if they have low hemoglobin and keeps giving them iron medicine, iron pills, and iron pills, that can lead to severe iron overload that can damage their brain permanently. So having the right diagnosis can affect the patient and the way we treat these patients. Wrong things can be done, wrong medicines can be prescribed, and at the same time, right treatment and right medicines can be prescribed. But it all starts with diagnosing the problem properly. That's what physicians should do. That's what doctors should do. You don't want to give paracetamol to somebody with malaria alone. You need to have anti-malarial medicine so that malaria could be treated. The right treatment only starts with the right diagnosis, which is why correct diagnosis using correct and latest technology, which is not something that our country cannot afford, to make the right diagnosis, especially in the people living in tier 2, tier 3 cities in tribal rural areas, is really what is needed if we are to ever change the face of sickle cell and thalassemia in India.
Right, Dr. Akshat, you have talked about how the diagnosis plays a very important role. Talking about advancements or innovations in diagnostic techniques that you believe can have a significant impact on improving patient outcomes, especially in a country like India.
Yeah, so as I said in the last question that we were discussing, one of the most important things that we really need is getting the right technology. Now, classically, testing for hemoglobinopathies has been done by a technology called as capillary electrophoresis. Then it has moved to now newer technologies that have evolved over the past 50 years to something called as HPLC, and then gel electrophoresis or isoelectric focusing. Now, all of these technologies have evolved over the years to be able to make the right diagnosis. Because sometimes you only get that one shot when the patient comes from the village and you find them at a medical hospital, or let's say AIMS, or a medical college hospital like PGI or SMS Medical College in Rajasthan, etc. And then they never show up again because they go back to their village. Either they die from their complications or never get a chance to come to the big city, big hospital. That one opportunity that you get to correctly diagnose the patient can be a lost opportunity if you are not utilizing the right tests. Secondly, doing the right test but not doing correctly can also give you wrong diagnosis. For example, HPLC is a technology to diagnose sickle cell and thalassemia. We use it all the time. I have one machine in my office and we do it right, left, and center. But if you let the specimen sit there for a longer period of time, or if it's too hot, and if you don't handle the specimen properly, it can give you false results and wrong results, to a point that sometimes people can have a wrong diagnosis and compound heterozygote state can be completely missed. So people who are handling the specimen, people who are controlling the specimen, people who are running the specimen, if you wait for 2 days to run the specimen, you'll get wrong results for sure. You'll miss a lot of test results. Just like an example, if you have a COVID test kit and that has expired and you start doing the COVID test and it comes back negative, surely it will come back negative because the test kit has expired. So not only do we need accurate testing, but we also need testing that can be done in the field and can be done quickly. so that the patient can get the result right away, maybe in 5 minutes or 10 minutes, and know their status. And then the patient can decide whether to seek a hematology care or come back, or also for the government to know exactly where those patients are. What is the right number of sickle patients? What is the right number of thalassemia patients? What is the right number of sickle thalassemia patients? And that makes a lot of difference. Correct diagnostic tests also help us deciding who needs blood transfusion and who does not need blood transfusion. Giving a blood transfusion could be life saving, and giving too much blood transfusion can also lead to iron overload and damage to the body. So it's very important that accurate testing and right testing, all of which is now available and actually cost effective and is being done in some part of the world, some African countries and some parts of even in our country, to get the testing done right there and then quickly in front of the patient so that the patient can go home with the report within 10 minutes, as opposed to then wait for the reports or sometimes not even know what the result was.
Dr. Jain, talking about, because you also spoke about how awareness level is low in countries and especially in India. So how can community engagement and grassroots initiatives contribute to increasing awareness and uptake of screenings of hemoglobinopathy, especially in undeserved, rural, far-flung areas?
The biggest advantage that we have, especially in our country, in India, is that everybody has a cell phone. You can imagine everybody, even in cities, even in areas within our big cities where there are slums, still everybody has a cell phone. I see that as a huge opportunity. Currently, we are running from here in America, we are running an international sickle cell study, a study that is checking and reaching people in far-flung areas in Nigeria, Uganda, Malawi, Zambia, parts of India, Gujarat, Chhattisgarh, far-flung areas in Rajasthan, just by leveraging the important aspect that everybody has access to internet and cellular phone. I think that is a very powerful tool, something that we have not utilized to our capacity in our public health programs in India. If we find a way to somehow start creating awareness, utilizing everybody's ability to be connected to the internet, to be able to promote people, to encourage them in common language. For example, when I'm running this survey in Valsad in Gujarat, I have the survey translated in Gujarati. When I'm running it in Maharashtra and Nagpur, it's translated in Marathi. So translated in local languages, right messaging, because these facts are real. 20% or more than 20% of children with sickle cell disease in our country don't get to live beyond the 2 years of life. They die by the time they are age of 2. That's a big number of patients. The family, the parents, many cultures in our community, in our country, do Janam Patri matching. It is not an extension. It is not really an exotic idea to think, hey, while you're matching your Janam Patri, maybe you should match your Gene Patri. If you are a carrier of thalassemia and you are having shadi ki baat chal rahi hai, then you might want to then make sure that the other person who you are deciding to getting married to should also get thalassemia testing or sickle cell testing by having proper appropriate screening methods, especially in areas that have such high prevalence, 50%, 40% prevalence of carrier state. It is absolutely important that we invest into prevention and utilization of the technologies that we have, that our people have, 1.3 billion people and more and counting. I think every single Indian person living in India and even non-resident Indian all over the world that we are, everybody needs to know their sickle cell and thalassemia status, because unless we know, we can't act on. You won't believe how many people I see here in America that are of Indian, Pakistani, Bangladeshi origin that did not know that their families had thalassemia and end up with children with severe disease that I end up taking care of.
to Dr. Akshat, and you've already talked about what public health initiatives can be implemented for early diagnosis, for awareness. But any other point that you feel that we have, because we've come to the end of the discussion, you feel that we have left on how regional and central policymakers can impact current care, and because from your unique perspective in seeing patients both in India and US, anything that you would want to add to the conversation and sum it up?
Sure. See, I've left India about 25 years ago. But having said that, I've been coming to our home country maybe every 6 months or every year to organize camps, to be able to create education at medical colleges all across the country, to give lectures and to train people. I think the government finally has got it right to a point where, especially under Prime Minister Modi, as vision of sickle cell eradication 2047 as an official program, thalassemia control program through the Ministry of Health, are very good initiatives. And there is a lot of now awareness about getting the tribal people having representation in our healthcare budget. I think it's very rightly said. But because of lack of expertise, lack of proper training, and lack of proper diagnosticians who can make the accurate diagnosis for all over the country. We have brilliant doctors all across India at amazing medical colleges, many of which were my teachers. But their expertise, and they are limited by being where they are. Our country is so wide and far and wide. We need more people who need to be trained. And certainly, if we are now starting to talk about diagnosis and identifying people in India, whereas somebody who is very close to my home country and wanting to impart that education and knowledge, whatever little we have gained, and we are already at the end line where we have cures available for that, to bridge that gap so India doesn't stay behind 20, 40, 50 years that it took for us in the United States or in UK or Australia to get to that point. I think we can bridge that gap to leverage the technologies that we have learned over the years can be brought to India if there is a will and intent to bring that expertise in the right manner, and then to make it available by using smart ideas, as we call as jugaad in India, to be able to get it out so that by being smart, by working smart, not hard, we can get these technologies long before they go through the whole process of trial and error that we went through in the United States. If we can deliver it tomorrow, that bridge needs to be created. So experts like us and companies that can do testing and provide the new medicines that are now available to our patients should be available to our patients in India also. And I think that would be something that will allow rapid, fast development of technology and will change the face of these diseases and many other diseases like diabetes and cancer, because we are all invested in getting our country and growing India and enjoying and bringing the country to its golden peak. And I think we should all take advantage of experts like me who are in medicine and in device development and in pharmaceutical industry all over the world to bring those technologies without minimum red tape or without red tape whatsoever, and leverage the education that we have as countrymen who are devoted to the country to bring it. Secondly, I think investing in the right technologies without having to think about what comes next versus having a proper program with proper leaders at the top to make the track program not just for 1 year or 2 year, but a 20-year or 40-year program so that these diseases are eradicated from our country. I think these two strategies will be most fruitful to get our country fast tracked into getting to cures within the next 5 years.
Right, Dr. Akshat, that indeed was a very, very enlightening session, and I'm sure our audience today will take a lot of relevant information on prevention and early detection of beta thalassemia, hemoglobinopathies, and of course, how we can, detect and diagnose early and make a change in the life of patients. Thanks for taking out time from your busy schedule and joining us today for this awareness session. And thank you to the audience. Please keep on following our social media pages for more updated information on health and well-being. Thank you, Dr. Akshat Jain.
Thank
Thanks
you,
for
Dr.
being
Baij.
here.